Practicing professionals represent the largest pool of trainees that can help us get up to speed to provide better care for older adults as the surge of baby boomers moves through the system. I think that we are seeing that they are receptive, they're willing, interested in the information, want more hands-on, experiential types of opportunities. I think and another important take-home message is that they need clinically relevant, practical information that they can take back to their practices, and that it needs to be new. It can't be the same old stuff we've been teaching about in terms of treating older adults for many years. That's a hard question to answer. We have some information, particularly through the recent ADA Vulnerable Adult Survey, of practitioners indicating at least some suggestion that a fair percentage of practicing dentists feel either very competent or comfortable or somewhat comfortable. Our concerns, of course, are that the response to the survey was only about a third, or 35–36%, so we don't know what's happening with the rest of the folks out there. I think we also are concerned about the new dentists coming out, how comfortable they are. They seem to report less comfort initially and compared to those who've been out more than 10 years. So I think there's sort of some good news and bad news. I think we need more information. I don't know that we have information about the comfort level of practicing dental hygienists or other individuals. I think one of the other interesting aspects of providing continuing education opportunities is the fact that we observe those practicing professionals who have been out for some time know general dentistry. They know how to do procedures. They've experienced lots of different patient situations. They've seen the issues in their offices, and that's what motivates them to want to find some answers through continuing ed. And I think that to some degree newer practitioners haven't encountered all those situations yet and may not be as sensitized to the issues. That is a tough question. I honestly think that it will start with incentives to be competent. I am not sure that our reimbursement system is structured necessarily for clinicians to provide great comprehensive care, especially for the vulnerable elderly, those with complex health problems, with limited resources or limitation in access to care. And I think without those incentives, there really is no reason for someone to want to be competent unless they're doing it out of the goodness of their own heart. So I think that when we can find ways to create incentives to do this care, to do it better, I think that will give people the motivation to be competent and to seek out training, whether it's through continuing education as practitioners or to pay more attention to it when they're students in school. I think it takes more time, and that's one element. I think there is a tendency to especially associate vulnerable older adults or those with more challenging presentations as not having as much in the way of resources, which is maybe another disincentive. I think sometimes the pace of a normal practice isn't conducive to the special care needs of the person who's coming in, who may be older and have some complexity. And I think dealing with some of the day-to-day issues that are associated with aging, especially those who have more complex presentations, such as dementia, that may be associated with behavior issues. I think other complexity of meeting those needs doesn't really fit well. Sometimes I feel like practitioners think it's like trying to fit a square peg in a round hole. I feel best practices in geriatric continuing education has a couple of key components. I think first of all, there has to be creative, interesting, clinically relevant material that you start with. And if you don't have that, it doesn't matter what else you do, people will not be interested and will not enroll. I think a second key piece is to blend in experiential components, which is what we have tried to do in our course. And I think practitioners are looking for that. I think there's a certain amount people can learn through a day-long lecture program. But ultimately, if it comes down to how to deal with a certain clinical situation or procedure, they sometimes need people to show them. And I think having experiential components is important. I think also it's important, of course, to evaluate carefully and thoroughly. Our program at Minnesota, our mini residency, has really evolved over the time it's been offered as we look at that feedback, not only on the course overall, but on all of the presentations and the arrangements that we've made and the flow of time during the course and whether people feel they're getting value for their investment in that course. And I think each year we change things, we try new things, and try to react to that evaluation in a positive way to make a course that is appealing to people. And I think what we're seeing is that over the years it's paid off.